Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Oncology Today as we focus on novel agents and strategies in the management of lung cancer. We have a great faculty today, Dr. Melissa Johnson from the Lung Cancer Research Program at the Sarah Cannon Research Institute and SERI Oncology Partners in Nashville, Dr. Ticiana Leal from the Winship Cancer Institute, Emory University in Atlanta, and Dr. Manish Patel, the Director of Drug Development at the Florida Cancer Specialists and Research Institute, and also Associate Director of Drug Development at Sarah Cannon Research Institute in Sarasota. As always, if you have any questions or cases you'd like to run by our faculty, just type them into the chat room. We'll talk about as many of these as we have time. I see one coming in already right now. There's a brief 1-minute pre-meeting survey and one for you to take after this. If you take that, it's in the chat room. You'll get a lot more out of this experience. We know a lot of people end up listening to our webinars and programs. If you're into podcasts, check out our Oncology Today series, including a recent program looking at the year in review and what's been going on in terms of non-small cell. We'll be doing a program next week with Professor Schmidt and Dr. Tulani focused on ADCs. I feel like we talk about ADCs every day. We'll be talking about it today, but this will be in breast cancer. And then the following day, we'll be talking about lung cancer again, but this time ALK-targeted therapy, particularly in the localized disease setting. Of course, the ALENA trial and the implications thereof. We're going to comment a little bit on HER2-targeted therapy, as we always do, and we'll be getting into that in GI cancers with Dr. Staub and Strickler in August when we come back with more webinars. And I'm all excited. We're going to be talking about neuroendocrine tumors. Don't do that too much anymore on August 29th. But today we're here to talk about a number of different new approaches in lung cancer. We actually are going to have 3 brief presentations from each faculty person as part of our meeting here today, a little bit different format than we usually use. We will be talking about the use of agents that are not approved and strategies not approved. A lot of what we're talking about today, in fact, will be that. Here's where we're heading. We're going to chat a little bit before we get into these talks, and then we'll get into the 3 talks. If we have time, we're going to pick up on some of the other things that happen at ASCO and that are going on right now in terms of lung cancer research. But I picked out this topic just to kind of get warmed up. I was thinking last night what I consider 2 advances that have occurred in lung cancer that we've heard about recently. One we heard about a long time ago, 14 years ago, when we found that it was very effective, but I don't think we're using very much of it. And the other is much more recent, and we're very excited about that, and for good reason. So here's what I want to get the feedback from the faculty on. First, Melissa, I've always loved the trial that came out of MGH looking at early palliative care. To me, it wasn't just about palliative care; it was about supportive care. It was everything we can do for the patient other than treating their cancer. They showed a survival benefit. I remember Tom Lynch at that time said, "If this were a drug, we'd be giving it." And I'm not sure we actually are giving it that much, but that's what I want to ask you about. And then the other thing I want to bring up, of course, is the pan-tumor approval of TDXD that we in education is really rocking our world. Now we're dealing with GU, and we've been dealing with them, but now with this approval, it's really an urgent issue. So again, just to get your take on this, Melissa, and when you think about patients with lung cancer, particularly a metastatic disease, which is a lot of what we're going to talk about here today, they have so many needs beyond, taking care of the tumor, so to speak. And it was interesting that this trial that they presented at ASCO, where they compared live, to online, they had like 22 centers, but I'm not sure how many places in the community have, embedded or online, available palliative care. Any thought, at your place, Melissa, what kind of services do you have available? Do you do early palliative care? And what are some of the needs that you see out there, particularly in lung cancer, in terms of, like I say, everything beyond treating the cancer?
Thanks, Neil. I loved this study. And in particular, I loved how it shows how the telemedicine that we we created the ability to use telemedicine during COVID, and it's the genie that won't go back in the box. We use palliative care in all of our patients in our clinical trials unit, and so I have the palliative care nurse practitioner see my patients on cycle 1, day 8, when they're starting trials, and it's really been very beneficial for after that first visit that they not have to travel back and forth to the unit, both for their drug assessments and for their palliative care visits. So we use a lot of telemedicine. My hat's off to the team who did that trial during COVID, and I think it shows that we need more of that in all of our cancer care.
Ticiana, any thoughts? I can tell you for us in CME, ever since the pandemic, not telemedicine, but teleeducation. I mean, what we're doing right now today, I never thought we'd be 4 years down the line still having a couple hundred people on the line, which we do almost every time we do this. But then I look at the clinicians, and I'm not sure it got picked up as much. And people are coming in for follow-up visits where maybe it could have been done telemedicine, maybe they're issues with licensing, going outside of state, et cetera. Ticiana, at Emory, what kind of services do you have available for patients in general, and how are you utilizing telemedicine?
Yeah, so we were a site for this study. So some of my patients were included in the study. And I was a big supporter of this study. And we actually frequently use telemedicine, not only in palliative care, but also in oncology as well. In palliative care, it has been, I think, extremely helpful. And I think the results of what I saw presented at ASCO mirrored the experience that I saw my patients tell me about. And certainly, I'm in favor of using telemedicine for palliative care and for oncology patients in general. In oncology, the way we use it is exactly how you said, to facilitate the care for our patients, to make sure that we minimize the burden of travel and the financial toxicity that comes with patients that require multiple appointments and they're seeing multiple specialists. And one sort of easy clinical scenario that I can give an example is somebody who is now on consolidation durvalumab, for example, after chemoradiation, and they prefer to go to a site that's closer to home, that's still an Emory site. And so they can have a telemedicine with me and then get their infusion closer to home and not have to make it all the way to one campus and go to a campus of preference. Those are simple examples that really help patients stay on track when they have to have prolonged therapies for a prolonged period of time. And I think overall, consistently we ask patients if they find that experience positive, and we have had really good results with that.
So Manish, of course, you are in a very unique situation running phase 1 research unit in the Florida Cancer Specialists, which is a bunch of general medical oncologists we've been working with for 15 years doing education programs. When the pandemic hit and everybody was trying to figure out how are we going to even do clinical research, I was thinking, this is going to lead to a lot more telemedicine and clinical research, people being able to access it. And I'm not sure that's exactly happened, but you tell me.
Exactly right, Neil. I mean, the concept is amazing. This trial was amazing, and hopefully this particular trial will continue to, grow the field of telemedicine, in particular with palliative care. But yeah, in terms of the clinical research aspects, there's only so much you can do with some of the trial visits, right? The adoption of the option within clinical trial design hasn't really taken off, but certainly nationwide during the pandemic, as well as the last several years, we've been able to incorporate them when we could, right? Is it a nationwide adoption for most visits? Probably not, but we certainly use them when we can, especially for patients who travel far distances, right? Very useful.
So the contrast I put out here is TDXD, and particularly now that we have this pan-tumor approval, or I think specialties outside of breast cancer and particularly, and also lung and GI, you guys have had some experience, but when you get beyond that, there's so many questions about that, but so exciting as well. And we're focused on new agents today, but this is a new approval that really is kind of, in a way, earth-shattering. Melissa, I'm just maybe let's take a look at the data first, just to remind us. We already knew that TDXD worked in overexpressing lung cancer. Of course, it has the approval in mutated disease, but you had pretty good response rates for, to me, it was like, I didn't know why it wasn't approved already just based on these response rates, but now I guess it is now with the pan-tumor approval. We have the whole issue of side effects, which I'm curious about your take on. We'll get to that in a second. And then, of course, the issue that everybody outside of lung looks over at you and goes, wow, you guys are using it in mutated disease. They usually have a few mutant patients, not like you all, where you see even higher response rates. And again, you have the whole adverse event profile. So first of all, Melissa, in terms of just lung cancer to start with, any thoughts about how this has affected your practice? What are you doing with people, for example, who are IHC 3+?
Well, I think, first of all, it is easier to get IHC for HER2 than any other test, right? Because we're doing it in breast cancer. And so the pathologist said, sure, I'll do it for your lung cancer patients, where I think in many other targets, we're further behind in getting access to who's HER2 overexpressed and who's not. So, because of course that doesn't get reported very easily on a NGS report. So it's a little bit easier to get the information. I'm still having to ask for it. And then it opens up an option maybe when you least expect it, because it doesn't seem to correlate with those patients that are HER2 mutated. And so just because you've looked at the NGS and there's nothing doesn't mean that they won't have some amount of overexpression of HER2.
So Ticiana, I'm curious. So, I've heard people say with HER2 mutant, some people use T-DXd first line, others do second line. I'm curious what you've been doing and what you're thinking about for overexpression.
Yeah, I think, the targets there are different. I think for patients with HER2 mutations, we're waiting to see the results of DESTINY-Lung4 to really see if this will be the optimal first-line agent. But I will say there have been clinical scenarios where I've reached for T-DXd as first-line for young patients, never smokers with very large burden of disease, who that they only have one shot at getting better, and the response rate's 50% with T-DXd with rapid responses. And we know that chemo IO, the response rate's going to be 30, and IO doesn't add much in the HER2 mutant population. So I have used it in frontline, but I do think that we need to wait for the data for DESTINY-Lung4 to really kind of make sure that is the right thing to do. I think this is a different population of patients, though, in DESTINY-Lung1, looking at the HER2 overexpressed populations. I think it's exciting to have the tumor agnostic or the, pan-tumor approach and approval. And this was based on 3 studies, including the DESTINY Pan-Tumor 1 trial, a colorectal tumor trial, and then our DESTINY-Lung1 trial here. Response rates are 30%. This is in the previously treated population. I think the overall survival there looks very promising, and I definitely am going back and making sure my patients that are in later lines of therapy have IHC checked. And this is either asking our pathologists to kind of go back and do it, or certainly prospectively making sure if you use an NGS panel that you check the box for IHC.
Yeah, when we went to the Oncology Nursing Society meeting this year, our theme was make sure there's an IHC HER2 on the patient's chart, because a nurse certainly can do that. Manish, it's also been really interesting with T-DXd, because you work with general medical oncologists, and it's interesting that they got a lot of experience with T-DXd with the breast cancer. So when these other indications came out, they were ready, whereas the specialists really couldn't pronounce half of the drugs. It was really kind of an interesting situation. But with breast cancer, we had a while to sort of flesh out how to deal with tolerability issues. I think initially we weren't aware that it was going to have the acute kind of chemo-like side effects, and now I think people realize that. And of course, ILD's out there, the issue of having to do repeat scanning, et cetera. How do you see the drug playing out in a community-based setting, Manish?
Yeah, I think you're exactly right. It's always helpful when you have an approval in a large population like breast, and everything that comes after it makes it a lot easier, right? And so, yes, in the general community, in oncology, medical oncology in general, lots of experience with this particular agent and how to manage the drug, right? So now that it's going to be used in lung as well as the tumor agnostic population, I don't think it'll be too difficult. I think most people know what to look for and how to manage these. It's kind of routine now. Most people are using this in their clinic on a daily basis. So I think it'll go well.
So one final question, then we're going to get into these talks. So getting back to the acute issues, Melissa, how do you, what kind of, pre-meds do you use for patients who are going to get in TDXD? And what do you see as they're treated? What do you see in terms of alopecia also?
I will say that in breast, 5.4 milligrams per kilogram was always the dose. In lung, I think initially we were giving 6.4, and there really is a difference, in my opinion, between 6.4 and 5.4 milligrams per kilogram. That said, I think all patients get 5-HT3 and NK1 and steroids because nausea is a side effect that we see with all of these exatecan antibody-drug conjugates. And the big side effect that we're looking for in 5% or less is interstitial lung disease. I think so. The majority of patients will not get that, but we're always thinking about it in our minds. I think nausea is the big one, and alopecia. It's not docetaxel alopecia where 3 weeks later you've lost all your hair. It's more like it comes out in little bits over time. So you go from having a lot of hair to having a little hair as you're maybe improving in terms of disease response and shrinking cancer.
All right, well, let's get into these mini talks. I'm really interested in this B7H3. It's really fascinating. The actual biology is incredible to me. So Manish, let's just chat a little bit about it. We spent, I think, an hour and a half talking about it on another program, but we maybe can get into the key issues.
Yeah, absolutely. Yes, we did talk about this in February, but it's such an exciting field, a lot going on, a lot of different agents targeting B7H3. So a lot more people are going to hear about this agent, this target, in the next few years. Just to recap, there are several immune markers and targets that are currently undergoing clinical trial work around the world, mainly for many years. The B7H3 is certainly one of them in the last several years that's been popular. The receptor for B7H3 has not been clearly identified, though. So it's interesting. This mainly expressed on outside of antigen presenting cells and tumor cells, but certainly has many different modes of action, different interactions. This slide shows one of them. I mean, molecular pathways, or people forget, are also involved with B7H3 expression. Interesting, this will probably influence a lot of the combination trials that will be coming out and have in the near future. The PI3 kinase pathway is one of them that does interact. MAPK is another one. So these are certainly areas that future trial design will center around in combination with B7H3 agents. Obviously, the target that we think about the most, or the field, is immuno-oncology. B7H3 in general downregulates numerous cytokines, inhibits T cell proliferation, along with downregulation of NK cells, macrophages, dendritic cells. So has both a co-stimulatory role as well as an inhibitory role within the immune system. So a lot of different ways of thinking about how this drug works. It's upregulated and overexpressed in many different tumor cells, and we'll show you a slide with the different cancers and how much they express B7H3. But it's thought there's a lot of literature out there on B7H3 expression and aggressiveness of disease, and it's thought that the higher the B7H3 expression, the poorer the prognosis. In terms of the tumor microenvironment, that's another field, another way that these targets work. Plenty of evidence and scientific data showing how cancer-associated fibroblasts are hyperproliferated, inhibition of apoptosis with that. B7H3 targeting this, just a the target itself promotes tumor cell growth, enhances tumor cell metastases, and obviously has a role in extracellular matrices as well. In terms of where it's expressed, so B7H3 is expressed in many different tumor types. What we think about the most, and when you look at the trial designs, prostate cancer, squamous non-small cell lung cancer, small cell esophageal cancer, that's what you're going to see most of the trials centered around, and that's because those represent the highest expressions of B7H3. So and today we're focusing on lung. So both small cell lung and squamous non-small cell lung cancer do overexpress B7H3. So many different targets with B7H3 over the years, right? So monoclonal antibodies have targeted B7H3. Antibody-drug conjugates, we'll talk about a few that have been developed that have targeted B7H3. Bispecifics are now in play. There are certainly CAR T, B7H3 CAR T programs that have been looked at the last several years, and even radioligand therapies. So really a wide array of different types of therapies, different mechanisms, and how these drugs work to target B7H3. Exciting field. So here's a short list of what's out there. Obviously, there's many other compounds that have been studied and that are being studied right now. We'll talk about ifinatamab, deruxtecan, a B7H3 ADC. There's also vobramitamab, another ADC. There's an HS293, which is another ADC. And then, of course, there's been the monoclonal antibodies that we mentioned earlier, as well as radioligands. We didn't list here in the table the other therapies. Several other ADCs are being looked at by other sponsors, as well as CAR T. So this particular compound has had a little bit more experience, a little bit more background, and been studied for several more years than the others. Ifinatamab deruxtecan is an ADC, obviously targeting B7H3. The drug antibody ratio for this is 4. Very stable linker payload, and the payload is what we have grown accustomed. It's a very popular target, as you guys all know, with the deruxtecan, so we know it very well. High potency, it's a topoisomerase inhibitor. Obviously has bystander anti-tumor effects. So the half-life of this payload is very short. And what's nice about this is there's a lot of familiarity with the payload across many different tumor types, right? So we conducted this phase 1 trial several years ago. We presented it at ESMO last year, as well as other conferences before that. It started off as a solid tumor phase 1 trial, right? It wasn't selective of particular tumor types up front. And it evolved into looking at, in the expansion phase, squamous esophageal cancer, prostate, and squamous non-small cell lung cancer. But during dose escalation, the 12 milligrams per kilo dose was selected to move forward in dose expansion, but they did continue to look at 8 milligrams per kilo as well as 12 milligrams per kilo. The drug is given once every 3 weeks. And in this particular phase 1 trial, obviously the primary endpoints were safety, DLT, but in terms of expansion in the dose expansion, overall response rate, duration of response, overall survival, PFS were certainly looked at. PKs and immunogenicity were looked at throughout the trial. They did not. For the prostate, there's different within the prostate group. We're not going to show the data within prostate and esophageal today since we're focusing on lung, but certainly very interesting data that came out with that, and certainly part of subsequent presentations. In terms of small cell lung, small population, right? Although this particular trial, as we see here, enrolled over 200 patients, and is still enrolling, still recruiting, by the way. There were about, in terms of this data set and what's been as part of the data cut, about 21 small cell lung cancer patients were part of this. As you can see here in the waterfall plot, certainly responses in a small number of patients, as low as 8 milligrams per kilo. But within the small population, again, about half the patients, about 52% of patients, the overall response rate of 52%. There were 10 PRs within these 21 patients. So certainly really interesting activity. Most importantly, what's really interesting is the median overall survival. Small number of patients, but in a refractory small cell lung cancer population, 12-month median overall survival is really interesting. Obviously, all of these patients had prior platinum therapy, and a high percent, over 80%, had prior immunotherapy. So clearly exposed to our common agents. In terms of the safety profile, very similar to the rest. This is just in small cell lung cancer, mind you, but very similar to with the other, with the overall safety data and within the other tumor types. Nausea, anemia, infusion-related reactions, fatigue are certainly the more common AEs with this particular agent. About more than half the patients will experience nausea. But none of these AEs are, very few of these AEs are grade 3 or higher. So manageable toxicity profile with this particular agent, and very few dose interruptions and reductions. And I believe there's only one reported death due to interstitial lung disease. So in terms of the nausea management, it's interesting. During the initial parts of the trial, there was no prophylactic medications given, and as the trial matured, it became mandated to give 5-HT3s as preventative for nausea. And the same thing with infusion-related reactions. 10 to 15% infusion-related reaction rate in this small population of just the small cell, a little slightly higher with the rest of the population. And because of that, there was a requirement for dexamethasone to be implemented as pre-meds as well. And that certainly did help. Nausea, I can just tell you from personal experience with this drug, tends to happen earlier on in the first several cycles, and it does seem to improve in the majority of patients as time goes on. So that's nice to see. And so certainly the infusion-related reactions happen earlier, though, and certainly something to watch. So exciting trials that are being conducted, that are being planned. Here's a phase 2 trial with ifinatamab in pre-treated extensive stage small cell lung cancer. So these are patients who've had a prior platinum line of therapy, but no more than 3 prior lines. And it's just the drug by itself, looking at the 2 established doses with efficacy, 8 milligrams per kilo and 12 milligrams per kilo. And so patients will be randomized. And that trial has been recruiting over the last year or so. And this is another very interesting, exciting trial that's being conducted that's starting to enroll. It's a phase 3 trial with this agent versus treatment of physician's choice in relapsed small cell lung cancer. So these are patients who have had prior platinum, but no other therapy afterwards. So really interesting trial, definitely needed. And so you can see here, patients will be randomized 1-to-1, and the treatment of physician's choice, such agents as topotecan and lurbinectedin, as you know. So really neat trials that are being planned for the small cell lung population. Here's another agent, another B7H3 ADC, similar type of payload, a topoisomerase inhibitor, similar trial design, right? Started off as a solid tumor trial, that eventually progressed into a dose expansion, looking at the the common tumor types, lung, prostate, and others. This was based mainly out of China. And here are the initial efficacy results in the small cell lung population. Clearly similar activities what we saw with the other trial that we just discussed. You can see here overall response rate 64% in the small cell lung refractory small cell lung population, pretty amazing. And then you can see here in the expansion phase, when they looked at more small cell lung cancer populations, the data held, right, 58% between the 2 doses. So certainly a lot of interest in these type of compounds. Although this was withdrawn, this was the phase 2 plan for their particular compound in the extensive stage small cell lung population, it's still pretty exciting to see further work being done with these agents. And there's certainly other combinations that are being done, trials that are being done with B7H3 in combination with many immunotherapy agents. And so a lot's going to be presented on this field, and look forward to it.
So really great stuff there, Manish. And Ticiana, I was just kind of flashing on this some of the data he was just talking about. We know like about 30% of the people who tune into our webinars who have been in oncology less than 10 years. And I'll say to you all, we didn't used to see waterfall plots like that in phase 1-2 trials. And, for people to go into trials nowadays, phase 1-2 trials is way different than it was when it was chemo A versus chemo B. But anyhow, Ticiana, any general thoughts about this? When I start seeing response rates, 20, 30%, start thinking about, hey, maybe it's time to start using it. But you tell me, any thoughts about where this is going to be heading and landing?
I mean, I definitely think it's exciting, number one, to have all these therapy advances, especially in small cell. I will say that response rate across trials over many years in small cell lung cancer doesn't always translate into benefits and overall survival. So while I think this is a signal and extremely promising in an early phase study, I do think we need to get endpoints of duration of response, which may be a better surrogate endpoint. And then certainly I think for small cell PFS and OS, maybe better endpoints than overall response rate by itself.
That's a great point. I didn't even think about that. You're 100% right. My head was more in non-small cell. That's really a great point. Melissa, we were talking before about this bispecifics and this Asian agent that was presented at ASCO, which targets VEGF and PD-1, and then maybe is going to replace PD-1. I have a case for you from the chat room. Keep that in mind as you listen to this case. This is from Rosanna. 75-year-old patient, T2N0, 1 centimeter lesion, G2 visceral pleural invasion, status post-lobectomy, recent cath with stent placement, so can't give chemo. Patient has a TPS of 70%. Would you give pembro alone in this situation without the chemo? And I'd say if there were a trial of this new bispecific, would you want to see I don't know if they should get on, but I mean, theoretically, do you think maybe we're going to be moving towards more than just single agent IO?
In the adjuvant setting in particular, yeah, why not?
Well,
I think the tricky part for this particular patient to get on a trial would be just that she's, had a cath, had an MI recently, but there are a lot of trials ongoing right now, Neil, looking at vaccines added to pembro. For example, Moderna has a cancer vaccine added to pembro in an adjuvant trial. There's, the TIGIT atezo in Skyscraper 15. We also have other novel drugs. So I think pembrolizumab is the first stop. Of course, we saw in the PEARLS data that was a little bit confusing that the benefit was seen in patients that got chemo. So that's a little bit of the bummer for this.
Yeah, actually, she mentioned the PEARLS data in her comment. I didn't mention that, but she brought up the PEARLS data. Interesting, yeah.
You don't let the perfect be the enemy of the good is my mantra always.
That's a good one. I haven't heard that one before. All right, well, let's go on to tumor treating fields. And Ticiana, I've always been fascinated by this. I remember we went to the Society of Neuro-Oncology meeting, I forget how many years ago, where we started talking about this. And I always liked the fact that it was different, although, of course, there's been a lot of controversy. And when you presented your paper on non-small cell, that just exponentially increased. So I was curious where things are nowadays with tumor treating fields, particularly as it relates to lung cancer. Can you provide us an update?
Yeah, definitely. Let's talk about tumor treating fields in metastatic non-small cell lung cancer. So to just kind of go back to tumor treating fields and to kind of explain this as a new modality to treat cancer, and specifically here, lung cancer. So basically, tumor treating fields delivers electrical fields that will disrupt cellular processes that are critical for cell division, as well as progression and metastasis, specifically here in the case. And so specifically in terms of tumor treating fields, what it does especially in dividing cells, is that it impacts mitosis and it leads to disruption of, the spindle formation. And that really was demonstrated in vitro and then subsequently demonstrated in vivo in mice models as well as in rabbit models. So that's kind of what led to additional preclinical studies that ultimately demonstrated that tumor treating fields can induce cell death by impacting specifically mitosis and spindle formation, leading to then apoptosis. It can also lead to cell cycle arrest and impact the blood-brain barrier. And it also may have an impact in immune modulation by leading to dendritic cell activation and immunogenic cell death. So tumor treating fields has several biophysicals and biological effects. It has antimitotic effects. It can also impact cell migration. It increases the cell membrane permeability and impacts blood-brain barrier. And in addition to that, can induce autophagy. It has some impact on replication in the DNA pathway, as well as potentially having, as we talked about, impact on immunological cell death. And it can also increase, for example, antigen dendritic cell presentation. All of this, in addition to preclinical studies demonstrating that the application of TT fields in non-small cell lung cancer models leading to decreased non-small cell lung cancer cell viability, that was especially enhanced when you combined it with taxanes or immunotherapy, was the background for the development of the LUNAR trial. And the LUNAR trial was a phase 3 study of tumor treating fields for metastatic non-small cell lung cancer that had progression on prior platinum-based chemotherapy. Specifically here, patients with advanced non-small cell lung cancer who had progression on prior platinum-based chemotherapy with ECOG performance status of 0-2 were included, and they were randomized 1-to-1 to tumor treating fields therapy and standard of care, which at the time included immunotherapy with the immune checkpoint inhibitor of choice of the investigator, or docetaxel versus standard of care alone. And in this study, patients continued on therapy as long as they were benefiting or until disease progression. The primary endpoint of this study here was overall survival. And we demonstrated here that tumor treating fields led to benefits in terms of progression-free survival. However, the progression-free survival benefit here did not meet statistical significance, as you're seeing in the blue versus the red, which is standard of care. In terms of response rates, the response rates between the two groups were actually comparable. There were actually 4 complete responses in the tumor treating fields with standard of care group. All of these were in the IO groups, 3 in the TT fields therapy group, and 1 in the standard of care group. But it did meet improvement in overall survival in the intent to treat population. As you're seeing here, the standard of care arm had a median overall survival of 9.9 months, and the TT fields plus standard of care, you're seeing here significant improvement in median overall survival with a hazard ratio of 0.74. And when we did a subgroup analysis, we saw that that magnitude of benefit was greater in the patients with PD-L1 positive, and certainly greatest in the patients with PD-L1 50% or greater. In terms of the safety of the LUNAR study, what we saw kind of mirrored what we saw in prior studies. The application of tumor treating fields in non-small cell lung cancer had been previously done in a pilot study with pemetrexed. And overall, what this study, just to summarize overall high-level safety results, is that this strategy was safe and well tolerated, and the majority of the events were grade 1 and 2 in nature. The most common adverse event that is higher in the tumor treating fields plus standard of care was dermatitis, that you see here is 43%. Versus 2% all grades. However, the rate of grade 3 or higher adverse events, specifically dermatitis, are quite low at 2%. And the majority of the events were reversible and improved with supportive care, including topical antibiotics, topical steroids, and if needed, dose hold and removal of the patches for 48 to 72 hours, and then application in a separate location to allow sort of the skin to heal and to improve. And those typically resolved. In terms of serious adverse events, any serious adverse events were 53% versus 38%. Any AE leading to discontinuation was 36 versus 20%. And any AE leading to death was 10% versus 8%. There were no deaths attributable to TTFields therapy in the LUNAR study. This is another very interesting study that was much awaited, that was presented at ASCO 2024. This is the METIS trial. This is an international multi-center phase 3 randomized study of tumor treating fields for patients with non-small cell lung cancer with brain metastasis. And in this study, patients with non-small cell lung cancer with brain metastasis were randomized 1-to-1, 298 patients to SRS, and then they received tumor treating fields therapy or plus best supportive care or best supportive care alone. In the best supportive care alone group, the patients were allowed to go on to salvage therapy with tumor treating fields therapy plus best supportive care. And you see there that 15 patients actually went on to receive tumor treating fields therapy plus best supportive care in the salvage therapy session in this setting. And what we saw here was a study that was designed to demonstrate as a primary endpoint time to intracranial progression. And to summarize the results of this study, again, included patients with advanced non-small cell lung cancer. These patients, about 50%, were on systemic therapy for their advanced non-small cell lung cancer. As you'd expect, the majority were either on taxanes, pemetrexed, or IO. And it did show a positive endpoint in terms of time to intracranial progression or neurologic death, as you see here, with a hazard ratio of 0.67. We're seeing a median time to intracranial progression of 21.9 months in the experimental arm with tumor treating fields plus best supportive care versus 11.3 months in the best supportive care group. There was no difference in overall survival between the two groups. And then in terms of quality of life, this study kind of mirrored what we saw in other tumor treating fields studies. Overall, there was a positive trend in most of the 18 scales and items assessed by the testing methods used here. There was improvement of global health status, physical functioning, and fatigue. And there was similar time to neurocognitive failure in both arms. In terms of the safety profile for the METIS trial, again, you're seeing here the differential, as would be expected in terms of adverse events, is skin irritation, pruritus, and dermatitis. Again, this is all due to application of the device, in this case on the scalp. But again, the grade 3 or higher events are actually quite low. 52% of the patients on the tumor treating fields arm developed device-related adverse events. Any grade, mostly grade 1 and 2, were skin, and only 3 were grade 3 or higher. And you're seeing on the 15 crossover patients that were on salvage TT fields plus best supportive care, there was one patient that developed a device-related grade 3 adverse event that was reported as headache. And there's a comparable incidence of grade 3 or higher severe adverse events between the two arms. So here is where the field is moving. As you know, we think about the rapidly developing landscape of treatment for patients with advanced non-small cell lung cancer. When we designed the LUNAR trial, patients were actually still receiving IO in second line globally. And during the conduct of the study, we had approval of IO in lots of countries, including the US and Europe. And certainly that kind of changed the way we're treating patients in second line and beyond, which impacted sort of the choices of therapies for the LUNAR trial. But as we stated, you know, the benefit that we saw with TT fields was greatest among patients in the IO arm, especially in the patients with PD-L1 positive. And so this is a study that is called the LUNAR 2 trial that's investigating the use of tumor treating fields with immune checkpoint inhibitors and chemotherapy for patients with advanced non-small cell lung cancer. And so this study will hopefully then demonstrate using both OS and PFS as a primary endpoints that tumor treating fields in combination can also lead to improved outcomes in the frontline setting. This study is actually ongoing. And that concludes my part of the talk.
Awesome. Really interesting. A couple of good questions for you, Melissa, from the chat room. But first, come back to you, Manish. You know, just this to buy into the concept that this modality could actually have a significant anti-tumor effect. What do you think about this meta thing with the brain mets? That looks, I'm trying to think of a hole in it. I mean, I guess it's not blinded, so I don't know, but I don't know. What do you think?
I think it's exciting, right? I mean, we've seen this data. We're using this in the CNS population already, right, with GBM. So it's not surprising that there's activity there, right, in the non-small cell brain met population. So certainly, it's going to be really multimodality therapies. People are going to be interested in. It's not going to be meant for everyone, right? But it'll be really interesting to see what the frontline data shows.
Well, it's also maybe, I mean, to me, like easier to focus on a small volume like the brain than the
Right,
whole
rather than
chest.
chest.
I don't know. Anyhow, a couple quick, then we go to the last talk, Melissa, but a couple quick questions for you. Well, first of all, we were talking about, I guess we'll call it IDXD. I think I can remember that one. Curious, a question about the quality and duration of responses that we're seeing. Did you have any patients receive it, Melissa?
Yeah, we also had it open in Nashville, and I think that is what we need to understand as the data matures. The duration of response was around 5 to 6 months, and that was in both data sets, both the IDXD data as well as the second Chinese ADC that Manish showed. What was interesting to me, though, is that in both data sets, I think there were patients who had been previously treated with irinotecan and topotecan. And so to me, that is at least promising, that there's something true and novel going on.
So maybe I'll give this one to Ticiana. This is from Swati in the chat room, who has a 73-year-old woman with mucinous variant lung adenocarcinoma. Wants to know what we know about responses to therapy, chemoimmunotherapy. I'm curious about whether you see targetable mutations. I don't even know how often you see it. Mucinous, Ticiana, anything different about that?
Yeah, it is a harder histology. These are more aggressive adenocarcinomas that are, certainly more resistant and poorly responsive to therapies. I do think that, we need to check NGS and check for all the markers, including HER2-IHC. Ultimately, this aggressive histology doesn't impact or select a specific choice of therapy. So I think, we recognize that it's an aggressive histology, and certainly more studies are needed, but NGS, PD-L1, IHCs, and then trying to individualize the therapy as best as possible in a multidisciplinary fashion. Obviously, staging will impact therapy that we're selecting as well.
So I feel like I'm talking about bispecifics and CAR T and myeloma and lymphoma almost every day nowadays, and they're struggling with, how are we going to do this? How's the community going to get involved? So interesting, but so exciting. We had a patient Tuesday night. We presented. Manish, you'll appreciate this. This was a patient who was on the bispecific teclistamab for myeloma, had been on it for a year and a half at the time I did a video interview of this patient. And the day I did the interview was the day the drug was approved, which kind of gives you that another example of why participating. And incidentally, now it's been a year and a half later, and the guy is still in remission on this bispecific. So when I saw that there was a bispecific coming to solid tumors, particularly small cell, and I was super excited, not only about the efficacy, but super interested to see how this is going to play out tolerability-wise. So Melissa, give us a little bit of taste of what's going on and what's about to happen here. Because tarlatamab's approved.
Happy to. All right. Well, right before ASCO 2024, we heard about the exciting approval of this drug, tarlatamab, which is a bispecific T-cell engager targeting both CD3 and DLL3. And it was approved on May the 16th based on data that we'll review with a response rate of 40%. But maybe even more exciting was the duration of response, 9 months, and median overall survival. We'll get to it, but spoiler alert, it was a year. So tarlatamab was approved based on this study, the Delphi 301 study. And, this is a drug that these bispecific T-cell engagers, we don't always give the same dose every time. And so that is one important take-home lesson about tarlatamab today, is that patients get a test dose of 1 milligram on day 1, and then weekly they get a step-up dose. And in the Delphi 301 trial, there were 2 different step-up doses evaluated 10 milligrams versus 100 milligrams. So you get dosed on day 1, day 8, day 15, and then every other week to follow. And patients in this trial had a 48-hour hospitalization, I think. Maybe it was 24 hours. The label also includes some just a 23-hour observation after the first, I think, 4 doses. Patients were randomized to these 2 doses with primary endpoint, objective response, secondary endpoints, including duration, PFS, and overall survival. And so, here's the objective response rate of 40% for patients that stepped up to 10 milligrams and 30% for patients that stepped up to 100. A little counterintuitive. More isn't always better. And this is one example of when that's true. Likewise, the disease control rate was a little bit better in the 10 milligrams. And here's the duration of response. 40 patients on the left treated at 10 milligrams and 30 patients on the right treated at 100. You see, importantly, that the first response is after 6 weeks. And so you see that as the little red triangle that goes all the way through. So if you're in these responders, they were responding right away. And then the patients were treated, they could be treated beyond disease progression. And that's the sort of pink dot square, I guess, on the slide. And so you see a number of these patients also being treated beyond progression. So this certainly is an immune therapy. It's working differently than PD-1 and PD-L1 in these small cell lung cancer patients. The median duration of response not yet reached, but was more than 6 months in 60% of patients in this trial. So the median PFS is probably stable. The median overall survival likely to mature a little bit more based on all the hash tag or all that the hash marks. But the median overall survival was 14 months in this group of refractory small cell lung cancer patients. And I think this is what made everybody sit up at ESMO in 2023 when Luis Pazarez presented this data and say, oh, this is super promising, and we'll look forward to seeing more. The relevant question across all tumor types these days is, does it work in the brain? This was a little hard question to answer from this trial because the trial required that all brain mets be treated prior to going on the trial. So that always makes it a little hard to see if it's working in brain metastasis. Nevertheless, the patients that had baseline brain metastasis did just as well as patients that didn't have brain metastasis, which is always reassuring. And on the next slide, you see a creative graph that tried to show the promise of intracranial activity for these patients. So at the top of the screen, this included there were 17 patients with brain mets that were all treated across the 2 doses that were greater than 10 millimeters. So it had to be a discrete nodule. And then as you look at the waterfall plots, the patients whose blue lines, or not waterfall, sorry, swimmers, the patients whose blue line started with yellow were treated with SRS, and those patients that had a white square had whole brain radiation. So irrespective of what you got, patients were able to have CNS tumor control. And I think more to come about that. Let's see. This slide shows preliminary safety. We see that patients that were treated at the 10 milligrams were less likely to have dose interruption or reduction compared to patients treated at 100. And then let's hover over the CRS just for a minute because we're thinking about those bispecifics that they use in hematologic malignancies where they are giving them steroids and giving them tocilizumab. And do you really have to do that here? The majority of patients had grade 1 and 2 CRS. Well, think about what that really is. That's a fever, which is grade 1, and then something that required intervention. So hypotension requiring fluids, hypoxia requiring a little nasal cannula oxygen. there were no patients treated with 10 milligrams step-up dose that had grade 3 CRS. So this is a different animal compared to those bispecifics that the myeloma docs and the lymphoma docs are wrestling with in the clinic. In general, I would go even one step further and say that when the CRS happened, it's on the next slide, actually. When the CRS happened, it happened early and not again. So if you are a patient that was destined to have CRS, look, this is a busy slide, but you can see it's either after the first or the second cycle, and then no more. So that's why the FDA label includes 24-hour obs just for the first 4 doses. And if you get through those 4 doses without having had CRS, it's unlikely that you're going to, and you can go back to the outpatient clinic. I think in the new wave of Amgen trials evaluating tarlatamab, I think we'll see that observation gets less and less and becomes an outpatient 8-hour observation and no hospitalization. The majority of patients can be treated with tocilizumab. 1 dose seemed to bring patients around for the most part. And some patients used supplemental oxygen, vasopressor support, just 1 patient in the trial. So just with the few minutes we have left, these are the new wave of trials. We've got Delphi 304. It's tarlatamab versus standard of care chemotherapy options, topotecan, lurbinectedin, or amrubicin, investigator choice. So that's a second-line small cell trial, right? We have Delphi 305, which is the maintenance trial for patients after they've completed concurrent carboetapicide durvalumab. Then they're randomized to tarla durvalumab versus durvalumab alone. And in the maintenance setting. And then finally, for patients in the limited stage setting after carboetapicide radiation, then they're randomized to tarla at a couple different doses, I believe, with pre-medications of dexamethasone and placebo. Now, of course, after ASCO 2024, when we heard the results of the Adriatic data, all patients in the U.S. are likely to receive durvalumab. And, I think Amgen's choice is to do it ex-U.S., in this fashion, or to make some amendments to their design so that U.S. investigators could participate. Just with a couple minutes left, want to mention this other DLL3 CD3 bispecific made by Boehringer. We'll call it 532. Very similar mechanism. Its phase 1 trial enrolled not just small cell, but also large cell neuroendocrine and other neuroendocrine cancers. Really impressive waterfall plot here too, right? We're seeing a response rate of 20% for all dose levels and 25% for patients treated at the higher step-up dose. And that was across all the different tumor types that were evaluated: small cell, large cell neuroendocrine, and other neuroendocrines like prostate cancer in the middle there. This certainly is a drug that many oncologists treating non-lung cancer patients are eager to get their hands on. Similar rates of CRS. Dysgeusia seems to be a class side effect. We've seen it with tarla as well. And a white cell count decreased. It seems like these bispecific T-cell engagers seem to make the white blood cells leave the periphery and flock to the tumor. And so we see that as the CBC showing whites and lymphs at lower levels. And so this Darion 5 is its frontline study, relapse refractory study. Again, evaluating 2 different doses, some step up. So everybody gets the same dose initially, once every 3 weeks. And then there's this step in dosing, they call it, where they get 1 or 2 doses weekly to follow. This is the frontline standard of care. Boehringer Ingelheim going big or going home. They've added it to the carboatopocyte atezo backbone for frontline use. And I think that's it.
So, yeah, and I don't think we're going to be able to get to talk about more of ASCO, but we talked a lot as it is. I was just thinking about, like in myeloma and lymphomas, we're seeing, things getting toned down, some patients not being admitted, mosunetuzumab, they call in oral steroids if they get a little fever. They have sub-Q, and so that's moving, down a little bit. What about CNS issues? That's been seen with the lymphomas, and what about infections?
Yeah, thanks for reminding me. We should talk about ICANS a little bit because that is a hallmark toxicity for these bispecifics, and it's a little. The mechanism for it is a little bit of a question mark. The good news is in tarlatamab trials, the incidence was low, and one dose of dexamethasone, 10 milligrams, really wipes it out. It can be confusion, it can be disorientation. In my experience, it's not subtle, but steroids do seem to help. And then infections haven't seen that as much, despite the fact that the white cell count is going down. It's a transient sort of extravasation into the tumor and then back out again. So I haven't seen this to be an immunosuppressive compound, although some are using growth factors for it.
So final comment from Ticiana, as I've been hearing all this, I'm having this image of a sick patient, an older patient, cardiovascular disease in the hospital with small cell, and now you're adding in cytokine release, et cetera, et cetera. Any thoughts about how that's going to play out?
Yeah, I think, we're still trying to extrapolate the data from trial to the actual real world population that we see. And in the trial, Delphi 301, patients had ECOG performance status of 0 to 1. So I do think it is something that those patients may require inpatient monitoring. And so here at Emory, we established a workflow for patients on tarlatamab. We have the ability to do the infusion in the infusion clinic, and then patients have a 24-hour observation in what we call our ICC, which is basically it's basically an urgent care that has 24-hour capacity. But for somebody like this that has good organ function, good family support, caregiver support, who's motivated and understands the risks, I would favor doing inpatient monitoring to make sure that, we can support the patient. Because for that person, grade 2 CRS may be a bigger challenge if they have a cardiac comorbidity.
So, wow, this has been great today. I think we all learned so much from the three of you. So Melissa, Ticiana, and Manish, thank you so much. Audience, thank you for attending. Come on back next week. I'm going to take a long nap before this one. I'll get Professor Schmidt and Dr. Tolaney talking about ADCs and breast cancer. Really looking forward to that. Had a great time here tonight. Be safe, stay well, and have a great night. Thanks so much, Melissa. Thanks, Ticiana.
Thank you.
Thanks, Manish.
Enjoyed it.
Have a good one.
Very much. Thank you.